This recording will go over Hirschsprung disease and biliary atresia. Hirschsprung disease is the result of an absence of ganglion cells in the rectum and to varying degrees upward in the colon. It is also known as megacolon. Hirschsprung disease is a major cause of lower bowel obstruction in newborns. Ganglia provide parasympathetic innervation of the colon. In Hirschsprung disease, ganglia are absent from a variable length of the colon extending proximally from the anus. Adequate peristalsis cannot occur in the infected colon, leading to a tonic contraction of the lumen that causes functional bowel obstruction, chronic constipation, and the passage of ribbon-like stool. So in this diagram here, this is the area of the colon where it has the tonic contraction and inadequate peristalsis. So because of that, the patient will experience constipation, potential complete bowel obstruction, and the ribbon-like stool because it's squeezing through a real tight area to get out. And then where this area is tight and not letting stool pass and that doesn't have peristalsis for the stool to go by, behind it, the bowel behind it, here's where the term megacolon comes from, is dilated with feces and gas. The ganglion cells are present here and normal in function, but then here we got that tonic contraction and inadequate peristalsis. Hirschsprung disease can cause complete bowel obstruction. Because of the constriction of the lumen, huge amounts of feces and gas collect proximal to the aganglionic portion, resulting in gross enlargement of this segment known as the megacolon. The enlarged segment of colon is usually normal in its function. In terms of manifestations, any child who does not pass meconium within the first 24 hours and who is prone to constipation or stool infrequency in the first month after birth is suspected of having Hirschsprung disease. The neonate infant or older child may exhibit signs of bowel obstruction, abdominal pain and distension, vomiting, and failure to thrive. Chronic constipation, beginning in the first month of life, results in pellet-like or ribbon-like stools that are foul-smelling. A rectal examination reveals a tight internal sphincter and the absence of stool, followed by an often explosive release of gas and feces related to the sudden but transient increase in rectal size. The definitive diagnosis is made by a suction rectal biopsy. Absence of ganglionic cells in the sample confirms the diagnosis of Hirschsprung disease. The diagnosis of older children can be confirmed with a contrast barium enema that demonstrates retained contrast. Children with Hirschsprung disease will have a non-relaxing internal anal sphincter. Hirschsprung disease can involve the entire colon, a very short segment of the colon, or any amount in between. Treatment involves removing the aganglionic portion of the intestine and a 1 or 2-step surgical intervention. A 1-step laparoscopic or transanal pull-through procedure is being used successfully with increasing frequency. For neonates, a 2-step surgical procedure is often used. First, to relieve the obstruction, a temporary colostomy is performed with the most distal section of normal bowel. Once the infant weighs 8 to 10 kilograms, the final step, a pull-through procedure, is performed. All ganglionic portions of the bowel are excised, and the normal bowel is reattached to the anal canal, and the colostomy is closed. Normal bowel function usually returns shortly after surgery. Please review the purple nursing care box for the child with Hirschsprung disease on your own. Biliary atresia refers to the obstruction or absence of the extrahepatic bile ducts. At birth, the liver itself is normal without inflammation, but the structural problems lead to significant cellular damage and eventual liver failure and death. Obstruction of the extrahepatic bile ducts causes obstruction of the normal flow of bile out of the liver and into the gallbladder and small intestines. As a result, bile plugs form, causing bile to back up into the liver. This process causes inflammation, edema, and hepatic degeneration. Eventually, the liver becomes fibrotic, and cirrhosis and portal hypertension develop, leading to liver failure. The gradual degeneration of the liver causes jaundice, icterus, and hepatomegaly. Because bile is not present in the intestines, fat and fat-soluble vitamins cannot be absorbed. This condition leads to malnutrition, deficiency in fat-soluble vitamins, and growth failure. In terms of manifestations, the child with biliary atresia appears healthy at birth. Manifestations that develop shortly afterwards include jaundice, stool that is light in color due to lack of bile pigment, dark bile-stained urine, and hepatomegaly. Investigation of liver function tests such as bilirubin, ALT, and AST, and clotting studies is important in establishing the diagnosis. Percutaneous liver biopsy can provide a definitive diagnosis if bile plugs, edema, and fibrosis are found in the presence of normal hepatic lobular structures. If bile is not draining properly from the liver, a procedure can be performed that allows bile to flow directly into the intestine through an anastomosis of the jejunum to the porta hepatis, the point at which the hepatic ducts join to form the common bile duct. The main goal of the procedure is to allow growth and development of the child until liver transplantation can be performed. Approximately 80% of children with biliary atresia will need a liver transplant by 10 years of age. Medical management involves treating the child's malnutrition and providing symptom relief. Malnutrition can be treated with special formulas used to increase calories, or TPN can provide essential nutrition. Fat-soluble vitamin malabsorption occurs with this condition. The fat-soluble vitamins are A, D, E, and K. Portal hypotension, with its concomitant problems of ascites and variceal bleeding, must be addressed in treating. Controlling bleeding, restricting salt intake, and using diuretics are essential in managing portal hypertension. During the early phase of the disease, in the first month of life, the infant with biliary atresia will appear jaundice, with mild hepatosplenomegaly and increased abdominal girth. As the disease progresses, the child may appear thin, with failure to thrive, marked jaundice, and evidence of rickets or softening or weakening of the bones caused by chronic vitamin D deficiency. Again, vitamin D is a fat-soluble vitamin. Pruritus becomes a major problem as bile builds up in the skin. The child may develop skin infections as a result of skin infections due to the itching of the pruritus, or xanthomas as a result of retention of cholesterol in the skin. In terms of nutritional support, providing adequate calories, aiding in vitamin supply and absorption, and preventing hepatic encephalopathy are important goals. Calorie counts, daily weights, and abdominal girths are important assessment parameters that provide the data necessary to improve nutritional support. NG tube feeding or TPN might become necessary at times. Supplements of vitamins A, D, E, and K, as well as calcium, phosphate, and zinc, are essential for adequate nutrition. In terms of skin care, bile acid binders such as cholestyramine aid in the excretion of bile salts and decrease pruritus and the development of xanthomas. Oatmeal baths can relieve severe itching. Preventing skin breakdown from severe scratching is essential. Wearing gloves during sleep and applying soothing lotions and creams for dry skin helps to prevent infection. Teaching parents activities to provide developmental stimulation and accessing resources available through physical and occupational therapy are essential nursing responsibilities. As the child awaits a liver transplant, efforts should be made to facilitate achievement of developmental milestones related to gross and fine motor skills and social and emotional abilities. Routine screening tests document developmental growth and can be used to evaluate interventions. Continuous monitoring for the development of portal hypertension is vital. The parents must be taught to watch for GI bleeding, severe edema, and ascites. If any of these conditions are noted, the physician must be notified immediately, as the child might need sodium intake restrictions, diuretics, IV albumin, or hospitalization. The nurse plays a critical role by listening to parental concerns, providing information and support, and encouraging parents to participate in their child's daily care. The child and family should be prepared for the possible death of the child. Biliary atresia is a life-threatening condition, and some children succumb to the disease before liver transplantation can be performed. Critical nursing interventions include arranging for and providing educational and emotional support to the child and to the parents so that they can effectively care for the child. The parents must be able to assume all home care responsibilities. They need to monitor nutritional intake, mix special formulas, manage NG feedings, provide skin care, give medication, and track their child's growth and development. Their ability to assess for GI bleeding, ascites, edema, and skin infections is critical so that treatment can begin promptly.